Yes, good afternoon, everybody. And at the outset, thank you, Dr. Pandey, for having me in your course. So, as told by Dr. Pandey, there's a lot of discussion going on about the Morganian cataract. They want to know the technique. So, I'm just showing this video that you see, this is the Morganian cataract. As you said, as soon as we puncture the capsule, the milky fluid, it starts coming out. So, here the trick is to keep on taking out this milky fluid. Here the intracapsular pressure is not high. The problem is with the visualization in presence of this milky fluid, and this capsule is fibrotic at many places, and you can see the zonules are also weak. So you need to be careful, and you should have these kind of micro capsulorhexis forceps with you. And here you can see I am trying to complete the capsulorhexis and take out the milky fluid again and again out, and so in this way you can very well complete your capsulorhexis in Morganian cataract. And now if you come to the chopping of these nucleus, of course they are difficult because they are mobile. There is a lot of space in the capsular bag, and they freely rotate in the capsular bag whenever you can see the nucleus. So, and moreover, the whole posterior capsule is exposed. One wrong chop and you can, rupture your posterior capsule. So the trick here is to go bevel down. This is 1.8 millimeter comic strips, and go bevel down, bury in the center, hold the nucleus, and tilt it slightly towards the anterior chamber, and you can see I give the equatorial chop. So in this Morganian cataract, this is the best way which I found to divide the nucleus in pieces. So once you do this piece, you can do further pieces, and one by one you can take these pieces out. And remember that the posterior capsule is totally exposed here, so you need to be very careful when you're taking out these pieces. So that was just to show you how we do the Morganian cataract as the discussion was going on. So I'm coming to the phaco in black cataract. We all know that the phacoemulsification in black cataract is a nightmare for any phaco surgeon, because they have the inherent problems in that the central nucleus core is very hard, and the posterior plate is very thick and leatherous in these cataract. This is the black cataract you can see, and this I'm doing under topical anesthesia. So, but of course, if you are in the beginning of your career, you don't need to do this one in topical anesthesia, because these cases, they can take longer time, and so you put a peribulbar block. So the idea is to disassemble the nucleus very well. So once we stain this capsule, and the size of the capsulorhexis should be adequate. If you have to err, you should err towards the larger size, because if you have a small capsulorhexis, it will be difficult to take out this hard nuclear pieces, and moreover, when you are chopping the nucleus, you may tear the capsulorhexis margin. So it's better to have a little bit larger, like 5.5, 5.75 millimeter rhexis, than having a 4 millimeter capsulorhexis. So here I'm completing this capsulorhexis. And now this is the technique which I use for black cataracts is what I call drill and chop, which I presented in 2010 European Congress in Paris. Here the densest part, the strength of this nucleus lies in the central part. You can see this central area is the strongest part. So what I do here, I go and drill here in the center only, and below the surface of this center. So by drilling this, what we achieve is that we weaken this central core. I keep on rotating the nucleus with my chopper and keep on drilling towards the center and below the surface. So once I drill enough, I have the advantage that I can put my phaco probe down at the base of this drilled area, and my chop is much more effective. It's not a superficial chop, and we can divide this nucleus in almost first place in two pieces. Now you see I'm drilling, and this time which you spend here is worth spending. Believe me, it really weakens this endonucleus. So once I drill in this central area, and now I hold this nucleus and give this chop, and you can appreciate that this chop goes down all the way because my position is very good. So now I don't intend to divide it completely. I rotate the nucleus here. I have almost 60-70% of the crack here. I rotate the nucleus, again hold from one side and complete this crack. So I'm very well within this capsular axis margin. I can make out where my capsular axis margins are, and see this division extends all the way down, and you have a good division of the nucleus. It almost always works in all the cases. And then you rotate the nucleus and further divide it into smaller pieces, and it makes your life much more easier. So, and it's always better if you can supplement with the chondroitin sulfate based OVDs to protect your endothelium. Remember that these cases may take a little longer time. You have to be patient, and but if you have effective technique to deal with these kind of cataract, they become very easy. So this is another case. Again, see, I drill in the center, keep on rotating the nucleus, and once I drill, you can see I can get a good effective chop. So that's how deal with these kind of brown and black cataracts. And now something about the cases where we may get torn capsular axis, as that gentleman was mentioning. This is the intumescent cataract. Basically it was a very bulky cataract. There was not much of the cortical fluid, as you will appreciate once I give the nick. I use the anterior chamber was very shallow, only 1.7 millimeter. I give the nick in the center, and see there is no cortical matter which has come out, but this is a very large bulky nucleus. So that's how I try to always make a very small capsular axis first in the center in intumescent cataract, and debulk them before going for the definitive large capsular axis. But here also it starts going in the periphery. So now there is no way you can salvage from here. You touch anywhere and it's going to go in the periphery. Now here, to salvage the situation, you need to debulk first before you complete the capsular axis on other sides. So whenever we have a torn capsular axis like this, you may get sometimes. So it's always, in my view, it's better to continue with the phaco rather than try to convert it if you are comfortable, because the closed chamber technique is always better than ECC. So here I complete the capsular axis on the other side. Now here, as Dr. Pandey mentioned, you need to reduce down your parameters. You have to do slow motion phaco so that there is very little turbulence in the anterior chamber, and you put very little pressure on this area. And if you do a direct chop, it's always better because it causes less stress on the zonules and capsular bag than doing the stop and chop. So here, and always do all this chopping maneuver in the center. So one by one you can take out these pieces from the capsular bag. So once you complete this, always maintain your closed chamber. As you saw, I put viscoelastic before taking out my phaco probe, and do IA, and try to do bimanual IA, which is better. And the area of the tear which is there, it should be aspirated in the last. So now we have uh, now this is the IOL which is being implanted in this case. So I put the IOL in the capsular bag, and I found that there was much of the overlapping on the optics. So I cut it with the micro scissor and trying to get into a appropriate size. So this completes the case. Thank you very much, Dr. Pandey.